I would like to acknowledge the traditional owners on the land in which we're meeting today, and I pay my respects to elders past, present, and emerging, and to any Aboriginal or Torres Strait Island people that might be on the call with us today. I'd like to extend a warm welcome to Dr. Nick Christelis, Pain Specialist Australia co-founder and medical director. Dr. Nick Christelis holds 2 specialist medical qualifications in pain medicine from the Faculty of Pain Medicine of the Australian and New Zealand College of Anaethetists and the Faculty of Pain Medicine of the Royal College of Anaesthetists in London, UK. Nick has over 20 years' experience and practices full-time within the field of pain medicine. He is a pain medicine physician with an interest in intervention, combining the full multidisciplinary team approach with pain interventional techniques like nerve and joint blocks, epidural injections, radiofrequency ablation, pulse radiofrequency, spinal cord stimulation, and other advanced neuromodulation techniques. Over to you, Dr. Christelis.
Thanks very much, Alison. I just wanted to check that everyone can hear me okay. If you can't, just let me know. So I believe we've got about 40 minutes. I'm going to talk you through a patient, and halfway through the patient, we'll talk a little bit about cancer and cancer pain. And like Alison said, whether you've got cancer or not, this is relevant for all. I will, and I'll do this via a presentation, and at the end of that, there'll be time for questions as well. So I want to get some feedback. I want to get some questions. Okay, so I'm just going to dive straight in. I'll confirm that my screen is shared, and if you can't see it, let me know, but it should be a full screen for you. I believe that there are way too many people suffering with pain. I started in anesthetics, as you know. I saw that there were a group of people suffering immensely, and within the public system, no offense to the public system because it does an amazing job, it was very difficult to start a pain clinic, which I knew needed to be done. So I just did it. And that was about 12 years ago, and it started off with a single doctor, and we now have 10 pain specialists. All of us are full-time. Most of us are full-time. We've got physios, psychologists, we've got dietitians, and we've got access to the team externally that we need as well. So we have a large network of specialists and allied health people, and we treat all forms of pain, mostly chronic pain. We do not treat enough cancer pain, but you'll hear a bit about that in a little while. So I'm going to dive in. This is one of the many patients that we've treated over the years. It was a lady who came to see me, and she had pancreatic cancer. And she'd had it for about 6 months, and she had severe abdominal pain. So you can just see pain within the abdomen, straight in the middle, and straight at the back. And if you have a look, these are just our questionnaires. Pain scores were between 3 and 10 out of 10. So she was debilitated by pain. She has a young family. It was affecting most of her function, as you can see. It was affecting her mood, ability to walk, ability to enjoy life, and ability to have a good quality of life. And that's what we're talking about here. We're talking about quality of life. Further questionnaire showed me that she was taking some medication, and I'm sure you'll have some questions about medications. She was on some Lyrica, which was giving her some side effects. She was on some Tarjan, which is an opioid, and it was helping, but it wasn't enough, and she was getting some side effects on that. And she was taking some immediate release oxycodone. The meds were helping, but they were giving her some side effects, and she was still struggling, and importantly, she didn't have that quality of life. I'll skip over that. She was married, she got kids, she just wanted to get on with her life. She didn't fill out our mood questionnaire and our worry questionnaire, which is an important factor, but nevertheless, I made my first assessment of her. So a youngish lady with pancreatic cancer, meds are not enough, the pain is debilitating. So my question is, what do I do, and what's my plan of action? Well, let's stop and let's kind of divert for a few minutes. I'm going to ask a question. I don't think I can get an answer from anyone, but I will answer the question. And you probably know what the answer is anyway. what is the most common fear for people with cancer, or what is one of the most common fears? And yes, you will have got that. The answer is pain, and it's a fact. There are many fears, of course, but one of the big fears is pain. Am I going to have pain? How's it going to be managed? And who's going to help me manage it? One of the many fears that people need to deal with cancer, and it's one of those fears that perhaps if we have ways of managing it, it's one less thing to worry about. But pain is one of the biggest fears. And pain is common. Pain is way too common for our liking. It can occur in up to 30% or more of people after curative treatment. It can occur during treatment, up to 60%. It can occur in advanced disease, so either with metastases or in the terminal end phases. And essentially, you've got about a 60% chance of pain at any point along the process. And that number is high. It's not to say it can't be treated, it's just that's the number. And this is something I feel strongly about. And whether you have chronic pain, whether you have cancer, that doesn't mean you should be suffering. And that's a completely different discussion. That's the definition of suffering. It's basically something negative, a fear, an emotion, a thought following some kind of threat. And it's a threat to you yourself. It's a threat to yourself. And we've all suffered in some way over our lives, and we probably will suffer. But just because you've got cancer, or just because you have pain, doesn't mean suffering is required. And I see that a lot in people I treat with who might be elderly. Oh, I'm old, I get aches and pains, and I can barely get from the table to the chair to the examination table. That's not okay. It's not okay to be suffering in pain. You may have heard of the WHO analgesic ladder, which is what is been used, and I'll come back to the slide in a second. It's what has been used in people with cancer for many years, since the 80s. And it was developed for worldwide distribution, not necessarily first world countries, but for anyone. And it's done a really good job. And it's basically 3 steps. Step 1, and this is to treat pain. Step 1, you use non-opioids. Step 2, you use weak opioids. Step 3, you use strong opioids. With or without, and it says there, adjuvants, with or without other pain medications. And that stood the test of time, and that wasn't scientifically developed. That was just developed. It wasn't based on much science. So if you have a look at the WHO ladder, and this was after 10 years of monitoring a huge number of patients, this is just the facts. And that was from 1985 when they started the ladder to 1995. So they monitored all the patients, or whole stack of patients. The facts were that 50% of patients were on strong opioids. 82% of patients, or 80% of patients, had oral use of opioids. Half of those used morphine. So morphine was the main opioid. 40% of the patients studied were using other pain medications, steroids, antidepressants, anticonvulsants, all of which can help some forms of pain. About 8% had nerve blocks and injections to help with pain control. And overall, about 75%, 76% had good relief, which is excellent. 12% was satisfactory. But the thing that alarms me is 12% did not have appropriate or adequate pain control. And that's a big number when you're looking at thousands of people. 12% is a massive number. 12 out of 100 people didn't get sufficient pain control. So let's fast forward to nowish, because life has changed. Medications have changed. Medicine has changed, and cancer now, for a lot of people, is turned into a chronic problem, because with medicine, cancer can be managed and sometimes even cured in a large group of patients. So what we've got now is we've got pain that is now common during treatment, and it can be common after treatment and sometimes curative treatment. You still have a high group of people with moderate to severe pain, 30%. Analgesic treatment is inadequate. This was just from a study based in 2023, so last year, that was published. 40% of people still are getting inadequate pain treatment. Chronic pain is now a problem in people with cancer because they are living longer. Life is carrying on, sometimes for long periods of time, and they develop chronic pain, which is debilitating, and it is common. And if you have chronic pain, whether you've got a cancer diagnosis or not, your quality of life is less. You've got psychological distress, you're fatigued, you're exhausted, you're physically exhausted, you're emotionally exhausted. So pain affects quality of life. And there is some suggestions that if you've got poorly controlled pain, it may actually change survival rates, and that's ongoing studies. But effectively, there may be some link between poorly controlled pain and shorter survival rates, which is another discussion we can have. So it's important to manage pain. That's what I'm getting across, and I think we all know that. Modern treatments have led to better survival rates and sometimes even curative, which is amazing. But it's got its consequences, and that is we have a group of people called cancer survivors, and they have their own problems, their own issues. And half of those cancer survivors can have chronic pain, which means we've got multiple factors that we're dealing with. And that chronic pain in half of the cancer survivors can be moderate to severe in a third of those people. So the bottom line is pain is common. Pain is not always well controlled. If somebody asks me the question, I can give you my thoughts on why, but that's perhaps a discussion for afterwards. So what that means is, and this paper I believe was from the USA, but it still has relevance in countries like Australia. There are a group of patients now that are developing other problems, and they happen to have had or have long-standing cancer. Opioids can cause problems. Dependence can happen, abuse can happen, misuse can happen, and unfortunately, patients are now getting scrutinized with opioid and opioid use. And I'd love to hear your thoughts and views on this at some point. So we're now opening another can of worms. So we've got the long-standing opioid use in people that are cancer survivors. Not to say it's wrong, but it just comes with a whole bunch of other factors. We also are moving away from pharmacological treatments for some people, so we're using non-pharmacological treatments for some. And that's an important one as well, which I'll elaborate on, but that might include some more holistic allied health approaches. It might include some more medical approaches, so nerve blocks, radio frequency treatments where we ablate nerves. We can put alcohol and phenol on nerves that effectively can cauterize, or we call it degenerate nerve protein. So alcohol on a nerve will just cook the nerve and it just stops the nerve from working. So we're using a whole bunch of other tools to manage pain so that there is not a high reliance on opioids, which means you have less side effects with opioids. And effectively, what we're moving into is this more integrative pain care. So it's not just an oncologist or an oncology team that manages pain. It's not just a surgeon that manages pain. And I feel very strongly about pain specialists becoming involved in this process. And sometimes it's really hard to do. And you as patients, you as family members of patients have a voice that can be heard. And it might be one of the things is a lot of medical practitioners or healthcare providers don't understand what pain specialists can do and are able to do. I was called to see a lady who was in her later stages of cancer because the family insisted that I was called by the treating medical team. And this lady had been in hospital for a month. And she was in incredible pain. She needed to get home to her family. And I performed an alcohol injection on the nerves of her neck just to try and help with her arm pain. And whilst it helped somewhat, it still wasn't enough for her to have a non-painful ending. And I kept in touch with her, one of her sisters, and we had a discussion after she had died. And the sister was upset that they had to stomp their feet to get a pain specialist involved in the care. That was one factor. And the other factor was the sister could get an idea about what would have been possible if we had seen her sister about 3 or 6 months earlier, or even as early as possible. So early access to appropriate pain care is, I think it's just a vital part of what should be done. And we've got a lot of work to do, and hence me standing here in front of Pancare, talking about these things, talking to you about the fact that pain is not okay. And if opioids are not helping, there are other options to manage pain. So let's carry on. So issues with opioids. Here are some issues with cancer and cancer pain. Opioids don't always work. 26% of people, so just call it a quarter of people, maybe non-responders or poor responders to opioids. And opioids can have their own problems in terms of effects on the system, on the body. And they're non-responders, poor responders, either because they've got neuropathic pain, which is a big problem for people, and that's a nerve injury pain, and that we'll talk about in the next slide. But neuropathic pain doesn't respond well to opioids. So opioids would be the wrong treatment, or not ideal treatment. Breakthrough pain is very hard to manage with opioids because opioids take time to work, and breakthrough pain is very short, sharp pain that occurs usually with mechanics and movement. So you take an opioid, by the time the pain is gone, and the opioid is working, the pain is gone. And of course, opioids over time cause tolerance, which means they stop working. And of course, psychological distress is a big factor as well, and opioids don't treat that. I've had many chronic patients over the years that end up taking opioids, not because it helps them with the pain, but it helps relieve anxiety. And that's a wrong use of opioids. Anxiety should be managed in its own way, not by using an opioid medication. So tolerance occurs, a dependence occurs, opioid-induced hyperalgesia, that's OIH, not IOH, is where the opioids over time, not only do they cause tolerance, but they can actually make the pain worse. And that's a chemical thing that happens in the spine, whereby the pain sensitivity dials up, so you get more sensitive. And it's difficult to explain this principle to patients, and a lot of patients don't want to reduce the dose of opioids because they think that the pain will get worse. But in fact, in these patients, the pain will get better if you're hyperalgesic and you drop the doses somewhat. So it's a complex problem, and hence should be managed or co-managed with people that are experienced in managing pain. So oncologists are fantastic at what they do, but they're not always fantastic at managing opioids. This is what we do. This is what we have trained to do, is manage pain. Another slide from this study, 40%, I'll just read it, 40%, there's a higher risk of 40% higher risk of 2-year all-cause mortality, like cancer recurrence and opioid overdose. So what that means is that opioids can reduce your life expectancy, and opioids may be associated with cancer reoccurrence. There are some studies done at great institutions like Peter Mac, where we now understand if you have a short course of opioids around an operation for a hip replacement, say, for example, that little intervention that an anaesthetist does only for a few hours, giving you a high dose of opioids, may result in 5 years' time, 10 years' time, your risk of cancer reoccurrence being elevated. We now understand that opioids drop your immune system. And this, again, is another discussion, but I just wanted to give you a flavor of it. Opioids weaken your immune system. We know that because people on opioids get infections, they get teeth issues, a whole bunch of things in terms of infection and immune suppression. And your immune system is what protects you against cancer and protects you against a whole bunch of other things. So opioids may be detrimental in some people. And of course, the risk of opioid overdose is also there as well, particularly as your body gets older, the risk goes up. Moving on to another problem in cancer is neuropathic pain, nerve-related pain. And neuropathic pain is where there is a we call it a disease or a lesion that affects the somatosensory nervous system, i.e., something happens to the nerves and the nerves trigger pain. And in cancer, there are many reasons why people get neuropathic pain. For example, that lady that I saw, she had an expanding mass on the celiac plexus, which I'll come to in a little while, and that was triggering some of her pain. So the opioids were not helping. So a cancer growing on a part of the body or a nerve can cause severe pain because it invades the nerve. And that lady that I mentioned that died with arm pain, she had a cancer on her brachial plexus, the nerves in her neck down to the arm. Bone metastases, so the bones can expand, and an expanding bone is painful. It affects the nerve fibers within the bone. So bone pain in cancer is a neuropathic pain problem. Surgery can cause nerve pain by the fact that it is a trauma to the body. And of course, cancer therapy, such as chemotherapy, can affect nerves. Chemotherapy-induced peripheral neuropathy, where you have chemotherapy, which is absolutely vital, but one of the side effects is it affects the long nerves, or the longest part of the nerve, which is the feet. Because it's a one long nerve from the spinal cord all the way down to the feet. So the most delicate part of the nerve is that nerve that's far away from the spine, and that's the feet, tips of the hands, tips of the toes. So the treatments can trigger neuropathic pain. So neuropathic pain is a big problem. And if you've got neuropathic pain, quality of life is lower, it's harder to manage. Breakthrough pain is also a big factor in some people with cancer pain. So, for example, this lady that I showed you earlier, and we were discussing her care, she was getting these bouts of short, sharp intense abdominal pain, the mass effect of the cancer within the pancreas, pushing on the celiac plexus. Bone metastases, surgeries, and treatments, again, they can all trigger neuropathic pain. So the WHO ladder is old. It's developed in 1985. That is a long time ago. And again, it wasn't developed because of science. It was developed out of necessity. So it's got to change, and it is changing. And this is what I wanted to bring your attention to. There is a fourth step, and that's an interventional approach. And that doesn't just necessarily mean a surgery or an injection. There are other things that means. That's the first step I'm going to bring your attention to, or the fourth step, should I say. And then the bottom, the black line, is integrative medicine therapy, which I'll elaborate on as well. So the step for the nerve blocks, the radio frequencies, the neuromodulation are absolutely appropriate for some people with refractory cancer pain. Spinal cord stimulation, peripheral nerve stimulation, even intrathecal therapy, where we deliver opioids directly into the spinal space, can be used to treat some forms of severe pain. So I had a lady with cancer pain from a pelvic cancer, and she was young. Every time she took an opioid, she basically just passed out. It was so strong for her, and she just wanted to be at home with her family. So we put in an intrathecal pump into her, which means just drops of morphine were delivered straight into her spinal fluid. And what that meant was she could stop her oral medications and not get the side effects. And she basically had no pain at the end because she was able to reduce all medications. She had some other issues, of course, but pain was not a factor for her. Neurolysis, which is what this case is I'm talking about, we used a chemical to destroy, interfere, affect the nervous system to stop the nerve signals, so she didn't need many medications. We can also use nerve blocks and we can also use nerve blocks and radio frequencies, where we can place a needle on a nerve and effectively burn and cauterize little nerves, and that can interfere pain and pain signals. And there are some other more advanced surgeries that can sometimes be used depending on the type of pain. So that's step 4, interventions. And if step 4 helps, then the opioids come down. And again, I just wanted to be completely clear. We're talking about medical approaches, but there is absolutely an approach that requires an allied health non-medical approach. And when I say non-medical, I mean a complementary approach, allied health approach. So psychological care is very important. Physical therapy is very important. Sometimes even acupuncture might be helpful in some. Yoga, mindfulness, hypnosis, all these things are very important. They're very important to manage stress. And we all have stress, whether you have cancer or not. Studies have shown if you just stop 2 or 3 times a day, we can all do it. We can do it right now if you want to, and take 10 slow, deep breaths. The balance between your sympathetic and parasympathetic nervous system changes, and symptoms of stress will reduce, and hence symptoms of pain will reduce, because pain and stress go hand in hand. So there are some very important things that can and should be done for each individual person, and everyone needs something different. And that's why you need somebody to make that assessment and work out what that therapy is. And we love oncologists, we love surgeons, but they don't have the time to do this. They're not trained to do this. They don't know how to detect these little things that might be going on. That's what we do. All right, we're about 25 minutes in. Let's move on and finish up with the lady we started with. This diagram will make sense in a few minutes, so just bear with me and let me explain this to you. That's the back of the spine. So those are what we call your spinous processes. That's what you can feel if you feel the middle of your spine. Whoops. There are your vertebra. The blue is your disc. So you got vertebra, disc, vertebra, disc. And what you can see is you can see some nerves that lie on the outside of the vertebra. That's called the sympathetic plexus, which I'll come to. In front of the vertebra, you've got the big aorta, which is the big blood vessel. And then wrapped around some blood vessels on the aorta are what we call the celiac plexus. And the celiac plexus is effectively the gateway to the nerves within the abdomen. So the pancreas is in front of the celiac plexus, and the celiac plexus would be the relay system for signals from the pancreas to the spinal cord, and that's the pain signals. That big blue line is the diaphragm. So what we do is we inject a needle, and this is for a celiac plexus block, which is not what I'm talking about, but I'm explaining to you. A needle is put in through the back, sometimes through little parts of the diaphragm, onto the celiac plexus. And then an injection is done to help interrupt pain signals. Now, as you can see, the aorta lies right on the celiac plexus. So there are some risks with that injection, in that you can sometimes poke the aorta, and it's not really a big deal, because there's some techniques where we actually go through the aorta to do this injection. But the celiac plexus is slightly more tricky to get a needle to than these nerves on the vertebra, which you can see. And those are called the splanchnic nerves. And so we've got 2 approaches to interfere with cancer pain from the pancreas. The slightly deeper approach, the celiac plexus, or the slightly more superficial approach, not so deep, the splanchnic injection. So I'll use another diagram to explain that to you. And again, this is similar to the last diagram. You've got the spinous processes on the back, you've got the vertebra with the discs and the yellow nerves on the outside, got the aorta in the front, and that big brown thing is the diaphragm. So a needle is passed, and it's not that big a needle, it's just a diagrammatic representation. The needle is passed quite deeply onto the celiac plexus, and we do an injection. And this is usually done under some sedation. Now, if I bring your attention to the slide on the right side, have a look at number A, or letter A. That's a celiac plexus block. You can see, and this is like cutting through the diagram, you're slicing through it like a piece of bread. The needle is passed through the back muscles. There's the kidneys. So just past the kidneys, way in front of the vertebral body, around the red aorta, and that's the celiac plexus, the little yellow splodges. So that's a celiac plexus block. Now, we as pain specialists have devised another way to do this injection, which is not as tricky and not as risky. And that's where we put the needle in the same trajectory, but we don't put it all the way to the front of the vertebra. We put it just on the vertebral body, and that is on the splanchnic plexus. And as you can see, the needle doesn't need to go in deeply, which means the risk is less. And that's exactly what I proposed for this lady. I proposed what we call a splanchnic plexus injection. Now, you can see vertebra. Oops. You can see vertebra. You can see spaces where the discs are between the vertebra. You can see all these little things, and those are metallic clips. And those are clips that were there. Clearly, they were clips that were done at the time of her pancreatic surgery or some form of surgery. You can see two needles pointing into the side of the spine, and you can see this black splodge, and that just tells me that the needles are in the correct position, and it's contrast. We inject the contrast, and you can see it flowing nicely up and down the side of the spine. And that's a splanchnic plexus injection, which is what she had. And when we did this injection, purely with anesthetic and a little bit of steroid, her pain went away. Her pain was gone completely. And she was essentially pain-free for about 3 days. And that went on for a number of weeks. Her pain after a period of time returned, which can sometimes happen, which was fine. And therefore, what we elected to do was to do the treatment again, but do it a little differently. You might be able to notice that those needles are a lot bigger. Those needles over there were the injection needles. They were quite small. The second phase of the treatment was using bigger needles, where the ends of the needles get hot, and effectively I heat up the end of the needle, and that burns the nerve, and it's called a radiofrequency ablation. I checked that the needles were in the correct position by injecting that black stuff, which is contrast. And then when I had done that, I injected some alcohol on the nerves as well. So I burnt the nerve, I injected some alcohol on the nerve. And then we reviewed things in a number of weeks afterwards, and effectively she was pain-free. And I saw her a number of months afterwards as a follow-up, and she continues to be pain-free, and we're now about 6 to 9 months down the line. She's pain-free. She's come to see me because she's got some back pain. She's got chronic back pain, and we are now addressing her chronic back pain with some medications and exercise before we do anything else. And so she was very happy with things. What I wanted to do was I wanted to use this as a description of a journey of somebody with cancer and cancer pain that can be managed not just by loading somebody up with opioids. There are some other options. And this is just merely one example. Sometimes it doesn't work out as perfectly as this. Sometimes it's a bit messy. Sometimes there's a little bit of residual pain. Sometimes we've got to do some other things. Sometimes it doesn't work. But I think if you've got the right pain, you've got the right patient, you've got the right diagnosis and the right plan, and of course you've got some expertise and experience, then there are ways that we can manage pain. I have spoken for about 40 minutes. I am very happy to take questions or hand it back over to Alison or Prue.